Good morning, good afternoon, good evening from VLU Grand Rounds. And today we have an exciting topic, early intervention for ulcer healing and recurrences. And we have a fantastic panel today. And I'm going to go right ahead and let Manj, who is our featured speaker today, share his screen and go at it.
Fantastic. Thank you very much. Just bear with me as I battle with the IT. So could you just confirm you can see the screen, though?
Perfect.
Fantastic. Good morning, good evening, everybody. It's a real honor to be part of this Grand Round session, and season's greetings to everybody. So it's my great pleasure to talk about venous leg ulceration, particularly early intervention. This is a topic of great personal passion and endeavor over many, many years. So it's a real pleasure. But I'm going to start with a case. So I'm sure many of the audience and the panel will have seen these sorts of patients regularly. A patient of 67 years of age, 4 months of right leg ulceration, and previous varicose vein surgery, and really want to emphasize the impact on her quality of life. So she's still working, really struggling. And again, I just put it to you, imagine having this wound on your leg all the time, every day, every night for 4 months, and all the associated problems, the pain, the dressings, the distress, the odor, the embarrassment, etc. So the impact of venous ulceration is enormous. And the real question is, how do we manage this? How do we deal with this to get the best outcome? Before we talk about that, I think it's worth really emphasizing that this lady is one of the lucky few. So she has made it to the specialist clinic. There are many other patients with ulcers who are in the system somewhere under other specialities. There's an enormous population that are stuck in a primary care setting, and an even bigger population that don't even make it to primary care doctors. So this is a really enormous problem. And I want to just emphasize that actually, she's one of the lucky few that's made it to the clinic where we can help her and offer her the right treatments. Many patients don't get that far. What's the issue with waiting for ulcers to heal or waiting a long time? Well, there's a very simple principle, which is cellular senescence. And the fibroblasts that we need to be firing on all cylinders for this ulcer to heal, they become increasingly useless the more chronic the ulcer is. And a number of studies over many decades have repeatedly shown the same thing. The best ability for the fibroblasts to do all the things they need to do for the ulcer to heal is early while the wound is relatively acute. So we have to act early to get the best outcomes in these patients. That's the principle. So how do we manage these patients? We're all aware of compression. I'm not going to go into the evidence of compression, but it is an essential part of managing patients with venous leg ulceration. I'll make one quick comment, which is about the adjustable compression garments, of which I've shown 2 photos here today. The recent Venus 6 study was very interesting. These garments were thought to be the next best thing. Patients can guide their own management and really have an important personal role in managing the ulcers. But actually, the healing rates were not as good as compression, multi-layer compression bandages, or even 2-layer stocking kits. So we have to be slightly careful to get the right compression, but clearly compression is imperative. But look, we're an interventional sort of group, and over many years we now understand that most patients with an ulcerated leg between the ankle and the knee and a normal arterial tree have underlying varicose veins. Studies report between 60 and 80% of people have superficial reflux if they have an ulcer and a normal arterial tree. So that's really what we need to focus on. And let's look at the evidence very briefly. 2 big studies I've had the privilege to be involved with. One was the ESCAR trial, and this trial included patients with healed and open ulcers with superficial venous reflux, and they were randomized to either compression therapy alone or compression with surgery for the varicose veins. Now, at the time this trial was done, 1999 to 2002, the treatment was stripping, and some of these patients had ligation alone, and there was a considerable delay between randomization and treatment. So bear all that in mind when we look at the results. But the results were still very stark, and the most clear finding was the dramatic reduction in ulcer recurrence. And so if you treat the underlying pathophysiology, you therefore reduce the risk of patients getting more ulcers in the future. So absolutely imperative. But of course, then we moved on to the EVERA study. So Professor Alan Davis is also one of the discussants today, who was a senior investigator for this important landmark trial. The publications are shown here, but this was a very simple study, 450 patients with C6 disease, randomized to either compression therapy and deferred treatment of the venous superficial reflux, or compression therapy and early treatment within 2 weeks to try and get the ulcer, the underlying pathophysiology dealt with as quickly as possible. And again, the results were very, very clear and very stark. If you deal with the underlying pathophysiology quickly, and I suspect this would also apply to other underlying pathophysiologies, be it deep venous disease, etc., the ulcers heal quicker. They don't come back as often. And again, in the very financially conscious situation we are in the UK, this is a highly cost-effective approach, if not cost-saving approach. So really highlighting the importance of early treatment of these patients as quickly as possible. So we understand now this is what we should be doing for these patients. They should get an early assessment of their arterial tree and start compression therapy straight away because the ulcers heal quicker and it's cost effective. But almost at the same time, they should have ultrasound imaging to look for underlying venous disease, particularly easily treatable superficial venous disease, which most of them will have. And the reason from the EVERA study, the ulcers heal quicker, they don't recur, but it's also enormously financially beneficial. So let's go back to this poor lady with the ulcer. We're clearly going to do a venous duplex scan, and here is a duplex scan result. So she had primary great saphenous reflux all the way down to the ankle. And so we're in compression therapy. The next sort of discussion really to have is how do we deal with a superficial reflux? The other comment I'll briefly make, so this is a laterally located ulcer, and actually I speak to a number of people who feel that this is a different pathology and therefore maybe should be treated differently. So I'm not sure I agree. Around 40% of the ulcers in the EVERA study were laterally located. Often the underlying pathology was great saphenous reflux, and their outcomes were just as good as the medially located ulcers. So I would almost ignore that while also, remaining vigilant for other pathologies, of course. But let's talk about the strategy for treating reflux. So in the EVERA study, we had certain principles. Principles were to ablate the incompetent truncal vein, the saphenous vein, ideally to the lowest point of reflux, carry on compression therapy. And as you would imagine in a big randomized trial, there were many different approaches that were used by the investigators. So foam sclerotherapy alone was actually one of the commonest or the commonest single approach that was used. But people also used thermal ablation, a combination of thermal plus foam, etc. So we had a variety of different approaches. And what was interesting is that the effectiveness of each of these approaches on healing was similar. In other words, the healing benefit was more related to how quickly you treat the vein, not which modality you use to treat the vein. So this is very important and a very important principle. But let's talk about subalter sclerotherapy. So because foam was so widely used in this trial, it was very common for patients to have treatment of the lesion veins that underlie the venous ulcer. And, we see this technique popularized by Ron Bush originally, the TERS approach, but also other investigators. And more recently, the evidence has sort of started to catch up. So there's a published randomized trial from our colleagues in Egypt with collaborators from London, but also some colleagues in Finland have also planning a number of studies. So, this is an area that's becoming increasingly accepted. So my strategy in this type of patient would be to ablate the saphenous vein, probably using thermal ablation, which is our standard approach down to just below the knee, but then treat the below knee venous disease, including the saphenous with foam sclerotherapy, and specifically targeting the subulcer plexus. as demonstrated in this picture. So I use this pincer type approach, so cannulation of the directly feeding veins above and below. And it's interesting, even if you can't see on B mode the veins, when you inject the foam, the leash of veins just lights up. So there's always a rich leash of veins underneath the ulcer, and the theory is that you're breaking that transmission of venous hypertension to the unhealthy skin. The ESVS guidelines support pretty much everything I've said, which is early arterial assessments with ABI assessment, ABPI assessment, compression therapy, but also early treatment of the superficial venous disease to accelerate healing and also to reduce the risk of venous ulcer recurrence. So just to conclude, I think the most important thing in these patients, well, two most important things are getting the pathway right, getting them to the right practitioner and the right specialist in a timely way, because only then is it possible to get the second thing, which is early intervention to deal with the underlying venous pathophysiology. And I really hope that with all the effort and energy that's gone into producing these trials, that we can really work hard together to implement, because this message is universal. Whichever country you practice in, I think these principles are going to be pretty universal. Thank you very much.
Thank you, Manj. That was wonderful. I'm sure that there are lots of comments and questions on this, and I'd like to welcome all people that are on YouTube as well. I'm going to go directly to Patrick Muck, who is my co-host today, and he's going to maybe ask you a few questions and comments, but I'd really be interested in where he thinks deep venous disease plays with venous ulcers.
Yeah, exactly. What I was thinking, Lowell, it was going to be my question. First, Manj and Alan, thanks so much for what you've done for patients worldwide. These two studies have clearly just changed people's lives. And as you said, not only is it a physical problem, but it's a social problem for them. I think last year at the AVF, we had some data showing folks with venous leg ulcers also suffered from depression. And you can see how, if you can't go out to dinner, you're not going to go out in a large group with this malodorous, embarrassing pathology that they have. So again, thanks for everything that you all have done to change care throughout the world. My question is exactly what Lowell was going to say. Do you think that I or us in the States perhaps are too aggressive? When I look at this like an arterial ulcer, and I think of it as a multi-level problem, and so C5 and C6, I'm very aggressive at either A, a CTV, or B, doing a venogram and IVUS. Do you think that's a little too aggressive in this patient population? And let me preface that by saying that for a nibble, there's no way I would treat that before I would treat the superficial reflux. But for a post-thrombotic, do you think I'm too aggressive at combining treating the underlying iliac venous compression in conjunction with superficial interventions as well?
Patrick, you're one of the gentlest people I know. I've never described you as too aggressive at anything, but I think you raise a really important point. Now, look, let me just start with some facts. So in the EVERA study and the ESCAR trials, there was not an aggressive policy for looking for venous outflow obstruction. This was in the UK setting. So people had duplex imaging essentially from the groin down. Now, look, I'm sure there are some people with a clinical suspicion where there was imaging performed higher up, but there was certainly not a routine approach to image up. I have no doubt that there are people in this study who, had we imaged, we would have identified venous obstruction higher up. But guess what? The benefits are there anyway. And so my approach would be largely pragmatic. We have a minimally invasive, globally available intervention that is not harmful, even if there's significant outflow obstruction. I mean, the Raju's original work has sort of demonstrated that. Now, obviously, FemPop obstruction is different, and that would hopefully be picked up on your duplex imaging. So I would say that so our approach is to really focus on the superficial system first. If there's a strong clinical suspicion when they first present, or if they're not doing well, then let's scratch beneath the surface. Let's look higher up and let's look for venous outflow obstruction. So it's really a pragmatic approach. There's also a cost element. I know that that's a complex issue in the US, but around the world, there are many systems that would not be able to support a very aggressive policy for venous outflow stenting. So that'd be my comments. I'd be interested to see what Alan and Kirsten think about that approach.
Patrick,
Well, before Alan, before you go on, I want to hear what Pat would say in rebuttal to Manj.
Yeah, I think that as much as I feel perhaps we're a little bit more aggressive, it is pragmatic. I talked to them, if they've had a, post-thrombotic, or if they've had a DVT and I suspect post-thrombotic, that's when we're a little bit more aggressive. If they got a history of a filter where I suspect that may be playing a role, those folks, I'm going to still be a little more aggressive. And to that end, again, you individualize, you look at the whole patient. Nothing is worse than you put a stent in somebody. We know that post-thrombotic, acute or chronic, that the patency is about 85% at 3 to 4 years. Nothing's worse than putting a stent in a 35 or 40-year-old person that's got 4 to 5 decades ahead of them, and then they come back and they're that 10 to 15% that occluded. It makes you feel about this big, and I'm not that very tall to start with either. But I think that we're the same way. We're pretty pragmatic about it. And as I said, there's zero chance I would treat a nibble with a venous stent before or during therapy combined with superficial therapy as well.
Thank you. I wish more people would have listened to these comments in the United States and in certain places in Europe as well. Alan?
You won't be surprised that I more or less completely agree with Manj. I think the key point here is actually to do your own clinical assessment. The answer is even if they've got a history of a DVT and you've got a leg with an ulcer, but there really is no other signs or symptoms of the post-thrombotic syndrome, there's no evidence of any swelling, etc., then I think dealing with the outflow is probably not the first thing I would do. If you've got somebody who's got a grossly swollen leg and a significantly high Valalta score, then yes, you may even opt, and very occasionally I might do the iliac tract before I would do something superficial, but that actually is a clinical decision. And I think what actually the biggest key of this is actually being treated by somebody who's experienced and actually works within a team who can offer everything. But I think the vast majority, as Manj highlighted, can be just have their superficial veins treated. And I think what's quite important, because it was mentioned about the Raju data, if you look at the Raju and Neglan data, where they did both simultaneously, their healing rates were still much poorer than in many contemporaneous studies. So I would just put that there as a caveat for those people who are advocating doing both at the same time.
Kirsten, thank you, Alan.
Yes, can you hear me? Or am I
Yes,
audible?
very
Yes,
well.
okay, good. Sorry, I wasn't quite sure. I must say, we also don't go straight for the outflow. I mean, we usually do the ultrasound ourselves. So if there is a suspicion, I would look further. And I'd probably even, to be very sure, go for an MR, venous MR scan to just make sure that there was something or nothing. But generally, we also like to first take out the swelling a bit with intense decompression, if possible, if the patient is willing to come like every 2 days for bandaging, and then go to surgery, the superficial surgery. I fully agree with you, Bench, and Alan, and well, Patrick as well. That is probably the right approach. Yes, yeah, we do so too, mostly.
So, thank you. I have a question. Now, do you believe that reflux is more important than venous obstruction in terms of the pathophysiology? Or this is to Manj.
Yeah. In the vast majority of patients with this pathology, yes, I do.
Anybody disagree with him?
No.
How about the role of perforators, Manj?
I think it goes into the overall venous reflux pathology. So perforators are plentiful in the leg. They are, if we look hard enough, we will find lots and lots of perforators. I think I wouldn't go very aggressively searching and treating the perforators. And I think if you're using a lot of foam sclerotherapy, which I would do in these patients, actually that deals with a lot of those perforating vessels as well. So yeah, of course, there are cases, particularly recurrent veins, where you might see big individual perforators that need to be dealt with. But I mean, I'm quite aggressive treating perforators, and I probably treat 20 a year at most, as opposed to 20 a week in some clinics, or a day even. And just one final quick comment back to Patrick. The other interesting discussion is, even if there is obstruction, actually, should we just be treating the subulcer plexus anyway, particularly with these sort of slightly more elderly, frail patients, who we're really not going to put them through a very aggressive procedure? I have a number of people with unreconstructible, extensive iliocaval obstruction, or they're too unfit, and just managing the subulcer area has got them healed. And it's so I think that's the real revelation for me, is the underuse and the encouragement to use the subulcer injections of foam.
Sorry,
Go ahead.
with the perforators, do you only treat them with foam, or would you also, if it's an active ulcer on top, would you actually incise? Because I'm always very hesitant to actually cause a wound in a wound.
Yeah, I mean, look, the devil's in the detail. If there's a big, like a mid-thigh Hunterian perforator, I'd often thermally ablate.
In the actual ulcer, that's what I was referring to.
Oh yeah, no, almost always foam. Almost always foam in that area.
And then try and get the ulcer to heal, then if need be, then later on maybe do a ligation if possible.
I don't think I've ever ligated around an ulcer. Yeah.
The difference between guys.
Yeah.
Kursat Boskirk, 1 minute. Kursat Boskirk thinks that foam doesn't work in large perforators and believes in using glue, and has had a vast experience. Has anybody had an experience using glue and perforators?
I have used it very occasionally, but I would say to Kursat that the vast majority of perforators don't need treating. And I would also say that actually, if you treat the superficial competence, and I think you are overtreated with perforators, but I think they're and what is interesting, if you look at the subulcer plexus study that we were involved with in Egypt, what is interesting, subulcer plexus injections actually improves healing, but actually there was no benefit for treating the perforators, and the perforators that were treated had no influence on subsequent recurrence. So I think the jury is very much out on how important the perforators actually are as an initial treatment. And if you look at the original Van Gent work on sepsis, they very much came out with the recommendation that the only perforators to treat were those who had recurrent ulceration and were on the medial aspect.
It's kind of interesting that the US has taken a little different slant, but I won't go into that. But I do have a question for the whole people. Maybe we're looking at this backwards. Should we be looking at the subulcer plexus and perhaps treating that first?
So we've gone full circle, haven't we, Lowell? Back to the TERS argument from Ron Bush. Look, I think that sooner or later, if you deal with a subulcer, but if you leave an incompetent trunk, that cannot be good for recurrent disease. And I think we've got enough evidence now to support treating a significant incompetent trunk. So that would be my argument. But look, I mean, is there an argument for treating the patient at the first presentation in the subulcer area and then subsequently dealing with the trunk? I think there's a conversation to be had around, the importance of timing is what I've emphasized today. So maybe that should be the pathway. I don't know.
And Lowell, can I just add on to that, is that in countries where it's very difficult to use compression, subulcer foam may actually be the quick answer, so that you don't have to put these people who won't adhere with comply with respect to wearing heavy compression. And I think that's something that needs further evaluation.
Comments?
Well, I have one more question for Manj and Alan and Kirsten really as well. Manj, you've done so much with Medtronic and the Spectrum data and cyanoacrylate, and obviously we teach our trainees, ablate to the lowest point of reflux. Well, below the proximal third of the calf, here in the States, Lowell's done a great job highlighting Varithena, but quite honestly, a lot of times that's not covered by insurance, or it doesn't make economical sense. So we use PCF. Do you think we should be looking for that distal GSV therapy with cyanoacrylate instead of PCF in your experience? Because again, Varithena is very hard, at least for us, to get covered.
It's physician compounded foam for everybody for PCF.
Oh yeah, sorry about that. Yeah, I'm sorry. Yeah, physician compound.
Yeah.
Why?
So we only use physician compounding foam, even though Varithena was largely developed in the UK. We don't have it here. It's too expensive. So in answer to your question about cyanoacrylate, so I have used it on occasion with patients' ulcers, and I like to stay away from the ulcer area. So I would normally ablate to the lower part of the calf, but not near the ulcer itself, and still use foam in the ulcer area, because it is an implant, and I don't want to have that exposure with the open wound. I think the mentality with foam in this area is you do get recurrent veins, you do get recurrent disease. I think a dentist mentality is probably more sensible. These people might need an additional treatment, an additional top up, and so I'm relatively relaxed about, with that sort of approach, and obviously counsel the patients accordingly. I noticed a comment from Kurzat about DVT. So it is interesting. So pretty much all the DVTs in the Everest study were calf DVTs in a center that only used foam sclerotherapy. And their protocol had a scan at 1 week. And so I suspect, a bit like EHIT, Lowell, I don't want to change topic, but I think if we scan too soon in these populations, we probably do see little events related to local passage of foam into the calf deep veins. I'm not sure of the clinical significance of those. So I'm relatively relaxed, and likewise relatively relaxed about volumes as well. But again, that's a different discussion.
Kirsten, last comment.
I must say, I would also go for like endothermal ablation of the great saphenous vein, as Armand said. And what I quite like to do is actually to then put foam, also physician made, not anything other fancy. We don't have anything available either. Even over the actual sheath, which is quite easy because you can push it down and then it goes very nicely into everything that's feeding it, which I found very convenient. I have quite nice success with that. And then obviously still afterwards compression and wound treatment also, that the patient comes back every 2 days at least and gets the wound treated properly. And try to get them to walk around and not just sit in a chair.
Thank you very much. We didn't talk about glycocalyx. We didn't talk about biofilm, but next time I think we will bring that up. But I think it's also interesting from a fact of, if we treat the subulcer plexus first, will we have perhaps a faster healing, and then couple it, because we always wait till the last moment to do the subulcer plexus. With that being said, we have 2 minutes to the hour. I'm going to wish everybody a happy holidays, and thank you for joining us. And I appreciate everybody being here. Have a good one.
Likewise, thank you, everyone.
But
Nice to have been here again. Thank you.
Bye-bye.
Bye-bye.